Good afternoon, everybody. A very warm welcome to our webinar on supporting recovery in primary care using the Uclp frameworks. I'm Julia Reynolds, Associate Director for Transformation at the Innovation Agency, and I'll be introducing the session, and I'll be joined by colleagues who have implemented and operationalized the frameworks. We'll be looking at how they work in practice and the outcomes at GP practice, PCN, and federation level. So I think we all know the drill by now. The housekeeping, all delegates will be muted for this session. The session will be recorded and shared with delegates after the event, as will the slides. If you have any questions about the presentations you've seen, please enter them into the Q&A box. The agenda, we will present 3 case studies, starting with Jane Bryers, who will present some work at PCN level around hypertension, Rhiannon Clark, who will present some work around respiratory at a GP Federation level, and Dr. Lauren Moorcroft, who will present around multimorbidity in a single GP practice. So by way of introduction, I think we're all very aware of the challenges that arose during the pandemic, which signaled a sea change in the way primary care did business, particularly the move from face-to-face to virtual, a shift from routine and proactive to reactive and urgent care, and practices have been delivering beyond the call of duty to provide care for their patients and to catch up from the backlog of work that the pandemic caused. As with any crisis, there are also opportunities to think and do things differently. And at the Innovation Agency, we saw an opportunity to support our region to look at supportive tools which may help them in this time of need. And as with any crisis, there's also opportunities to look and think differently and do things differently. And at the Innovation Agency, we saw an opportunity to look at these tools which might help. And there are several resources out there, and we're just thinking about one around the proactive care framework, but there's a lot of other resources out there, but this is a really good tool that's really been proven to work. So this tool will help restore and support proactive care for patients, particularly vulnerable patients, offer them a personalized care approach, and consider assets in the practice, such as more involvement from the admin team and additional roles, such as social prescribers and healthcare coordinators. And it allows practices to adopt a systematic approach to the whole practice to make improvements in patient outcomes. So here we've got our challenge. Many of you will be familiar with the Core 20+5 agenda, which is guiding us in our approach to provide fair and equitable care. As you can see, CVD particularly is mentioned, and hypertension and lipids are some of the core 5 areas we're tasked with looking at. And we at the Innovation Agency are running a range of activities to support our region, and we have these as our priorities. We're all coping with the aftermath of the pandemic, and excess deaths traditionally have been very great in our region. And these traditionally in the north, we have experienced poorer health than our southern counterparts for a number of reasons, including our industrial legacy. But we're continuing to experience high levels of deprivation, and we're facing a huge workforce crisis. Even in our region, with our primary care workforce, there's huge variations even now in workforce profiles. And I just thought I'd show this slide to just demonstrate what the challenges are. This is just one slide that's looking at hypertension in Lancashire and South Cumbria, but every region follows a similar path to this. We were doing reasonably well in 1920 from the figures from the QOF. We're actually looking at a reasonably high percentage of our blood pressure treated to target, and we were being ambitious that we were well on the way to meeting 80%. But then unfortunately we had the pandemic and we fell to below 50%, in some cases even lower than that. And you can look at what the opportunities are there around the improvements and the amount of events, heart attacks and strokes, and the amount of funding that we can potentially save, or that we will have to bear the cost of if we don't move into a recovery phase. We're very fortunate now because we have a lot better data than we had previously. We've got the CVD Prevent audits, which will be issuing their next audit tranche next week. And we also have in Cheshire and Merseyside and in Lancashire and South Cumbria, we have very good stroke dashboards and databases. So Cheshire and Merseyside, we have the Cypher database, which will be available soon. It's not quite ready yet. So just moving on to the Uclp frameworks. For those of you that are familiar with these, this just shows the conditions that they support, the main long-term conditions around CVD and respiratory. They're making more frameworks as time goes on. So I think they're going to be delivering some heart failure and mental health ones in the future as well. And this outlines the approach. So it's an overview of the frameworks and the principles under which they operate. So virtual first, an idea of the primary care workforce, including a step change in self-management and digital technologies as well being key to this. And this is another thing that's come out from the pandemic, the opportunity to be able to deliver care in a different way. And this framework is very practical. It allows practices to break down and stratify into low, medium and high priority groups so that those higher priority groups can be looked at first. And then there's a range of support that can be given by different clinicians for the different priorities. And certainly we shouldn't forget about the lower priorities because they will be moving upwards if they're left alone. So they could be communicated with remotely, have maybe remote consultations with a range of support services. So just to outline the consistency of the frameworks, we have the search tools, which allows the stratification and the pathways that prioritize the patients for follow-up, and we'll be hearing more about that in our presentations. Scripts and protocols, training tools that can be used for different staff groups, and also a range of remote monitoring resources. I just thought it would be helpful to identify that there are opportunities in primary care which can be supported by these frameworks. This is just a summary of the DES, the Impact and Investment Fund. And actually, we've had some very good feedback from people that we've worked with around meeting the requirements of the DES with some of these initiatives. So, for example, hypertension and lipids, atrial fibrillation, but then there's also other things that can be met by personalised care, for example, and environmental sustainability. Practices have also found that there's support for using the additional roles that they have and the ability to get and apply for these roles. And apparently that funding pot is very underspent. So if any of you haven't applied for your additional roles, there's an opportunity there, I think. Also supporting CQC assessments and other quality improvement activities. So I just round off by identifying how this works in practice. And this is a patient that has sort of a number of different challenges. And this is just a summary of how those challenges can be met. And it's a flow, really, and actually sort of working towards how practices can understand how that flow works and who does what and when, which is always useful. So actually finding the patient and having a conversation with the patient, understanding their challenges and issues, understanding what the wider support can be given, things like smoking cessation, home monitoring and training, and demonstrations of how you can monitor your own blood pressure at home, thinking about behaviour change activities, diet and exercise. And then there's the medicines optimization, looking specifically with a clinician to deliver a sort of shared approach, shared decision-making approach to the medication support as well. So very much the lifestyle factors going hand in hand with medicines optimization.